About the antibiotic Dalbavancin, it is now available in India for use in the intravenous formulation. It's a lipoglycopeptide and it's derived from teicoplanin. So it's a modification of teicoplanin, and the major change this modification has made is that it has made it a very long-acting molecule, and the spectrum is similar. It is intended for gram-positive infections, both sensitive as well as resistant, Staphylococcus aureus and Streptococcus. It's in use since 2014 when it received the FDA approval for use in skin and soft tissue infection. Now that's the only approval it has, but it has been used in other conditions because it attains excellent tissue levels. So osteomyelitis, endocarditis, people have used it in different places. The beauty of the molecule is a long half-life, and it can be given as a once weekly dosage. It has activity against enterococci, which is vancomycin sensitive. And generally, when we look at the genes responsible for vancomycin resistance, the two most common ones are VAN A and VAN B. So if it is a VAN A, there is no activity. So it's vancomycin resistant, and it is also resistant to dalbavancin. Vancomycin B, both dalbavancin and teicoplanin work. So you can almost consider clinically dalbavancin as a substitute to teicoplanin or as a substitute to vancomycin. So those are the conditions where we will consider use of this drug. What is the dosing? In skin and soft tissue infections, a single dose on 1500 milligrams IV, or there is a 2-dose regimen. You give 1 gram IV day 1, and then after 1 week you give 500 milligrams. And if there is a renal insufficiency with a creatinine clearance of less than 30, you can modify the dose, a 25% decrease in the dosing. And what is our interest? Our interest is in the long half-life. Many of the gram-positive infections require weeks and months of therapy. And in such case, if we get a weekly molecule, life becomes very easy, both for the patient and for the doctor. And it is less nephrotoxic than vancomycin. So it has been tried head-on-hand with vancomycin, fair number of population. And if you consider the vancomycin nephrotoxicity to be somewhere around 8 to 10%, it would be around 3 to 4% with dalbavancin. So it's a less nephrotoxic agent available for similar spectrum for which we use vancomycin or teicoplanin, approved only for skin and soft tissue infections, and the most attractive proposition is its long half-life.